Welcome to another episode of the Lifeguard Project podcast brought to you by the Ben Carlson Foundation. This episode is a must listen for anyone curious about all things drowning, from professionals to the public. We split these episodes into a two-part recording in order to discuss every detail of everything from physiology to advancements in care, global policy, studies, science, and every aspect of drowning management, from prevention all the way to the hospital. Because today we're joined by Dr. Justin Semprot, an emergency medical physician and drowning specialist who's spent the last 2 decades advancing drowning resuscitation. In 2006, he co-founded Lifeguards Without Borders after seeing the massive and preventable global burden of drowning, especially in low and middle income countries. In the last 5 years alone, Justin has lectured on drowning resuscitation to over 10,000 pre-hospital providers, including Air Force paratroopers, Navy SEALs, and other Special Forces medics. He has also helped spearhead numerous studies which have become the latest science for industry-wide as well as statewide drowning protocols. Once again, this is a 2-part series and a must listen. Thank you for always listening and enjoy. Justin, welcome officially, and thanks for, even though it's going to appear like we're on a cruise ship hanging out, I know your schedule's super busy. Obviously, even when you're here, right, you've got stuff lined up. So thanks for taking the time to sit with me to do a little podcast interview and talk drowning and all the above.
Yeah, absolutely. I'm excited that we could finally catch up and have some dedicated time.
Yeah, absolutely. So just starting out, give us a once over on like where you were born and where you kind of grew up and where life started for you.
Yeah, absolutely. So I was actually born on a military base here in the U.S. and then very quickly my dad was deployed to the Philippines, and so I kind of spent my my formative years up until 1991 in the Philippines, and had the awesome 10 going on 11-year-old experience of being there when Mount Pinatubo erupted. And then the next day, a typhoon hit and kind of leveled all of the American bases, and got to play in the ash and watch the terrifying lightning and feel the ground shake, and then fly on helicopters and airplanes and cargo liners and ships in cardboard cities across the South Pacific until we eventually made our way several months later to Florida. And then that's where I spent the middle school and high school years. And then in high school, was a long blonde-haired, scrawny surf rat kid that wanted to fight the world, and went out for the beach lifeguard organization there in Jacksonville Beach, which was volunteer on weekends and holidays, and then paid through the city on the Saturdays and weekdays. And that's really where I kind of, got into the world of lifeguarding and life saving.
And how old are you when you started guarding officially?
Officially 16.
16 years old. Yeah. Okay, cool. In Jacksonville. Before, I always like to ask people, before your first interaction with like water, or when you learned like swim lessons or whatever, like where was your first actual like, oh, like I'm swimming in water, like memory, as an initial thing too, before like becoming a professional?
Yeah, great question, because I have a couple of thoughts on that. So I kind of grew up in the era of like Cub Scouts and learning to swim by just being thrown in the water, and then you kind of figured it out, and then you get thrown in the water and figure it out. But even younger than that, there was a time when I was probably 4 or 5 years old, and I still have this very distinctive memory. We were already living overseas and then had come back stateside, and to hear my dad tell his part of the story, we're in some motel with the cement swimming pool and a diving board in the center. And then he kind of dozes off and then looks up and sees just my arm floaties there at the surface and me on the bottom. And I have a very distinct memory of sitting peacefully on the bottom, looking up at the sun refracting through the water, and just being completely like at peace with it, not realizing the danger that I was in. And then my dad piercing through that, pulling me out. All of the adults are yelling and screaming, right? Never needed CPR, never needed rescue breathing. But now I thought I was in trouble, and all of the adults are upset, and now we're not allowed to swim anymore that day. And just at the time, not being able to figure out why.
Sure.
And you were 4 or 5, you said?
Yeah, 4 or 5 years old. And even to this day, I just have such a core memory of that piece. So that even when I'm scuba diving and I'm on my safety stop, I always just kind of look up at the sunlight coming through that water, and am at like that complete peace with it, and, you know, completely unaware of the hazard and the danger of, you know, 2 more minutes, 3 more minutes, 10 more minutes down on the bottom, and I wouldn't be here today.
Okay. Well, I can't believe we haven't gotten to that yet, but this is the whole point of the podcast. I love that. So, do you think that, I mean, was that just like a one-off, or is that the reason you went down this path of drowning stuff, or did it have an influence?
Yeah, I don't think it had an influence. It was just kind of one of those one-off things that happened. But especially living in the Philippines, there were always typhoons, always floods, always tornadoes, always earthquakes. And grew up even in the on-base house that we were on. We called them spider houses because they were concrete block on stilts, because sometimes the first floor would completely flood for 3 or 4 days, and we got to have a camp out in the hallways of the house for a few days until the water receded. And so really in those early years, just grew up with that like respect for the water, respect for the environment, and just the awesome power of nature, and how small we are against it. But then the other side of that too is, I remember when the eye of the typhoon passes over, all of the families coming out, whether it's standing on porches or going down, checking on each other. Everyone okay? Anyone need anything? Okay, wind's starting to pick back up again, and then retreating back in, and, you know, really feeling like we were on an outpost of civilization against the elements. But you know, the human resilience and the energy was there.
Sorry for interrupting. Do you want to hear Dr. Justin Semprot actually lecture in person? The Lifeguard Project is bringing its first annual event called the Responder Roundup in San Luis Obispo, California, at the Performing Arts Center in San Luis Obispo. Dr. Justin's going to do his drowning resuscitation and airway and ventilation course. The focus is going to be hands-on skills from lifeguard basics to BLS to ALS, all the way to critical care management, intubation, supraglottic airways. We're going to have ultra-realistic mannequins that are scanned off of a real human airway and articulate like real tissue. You'll be able to challenge yourself and put that jaw thrust to the test and see if you can actually have a mask seal. Everyone I tested along the way had some struggle and learned a lot. And then at the end, we're going to have a happy hour and community film screening of Part of Water, the Ben Carlson Foundation documentary about the lifeguard who died in the line of duty in Newport Beach, California. This is going to be open to the public and to the broader community. Day 2, we're going to be landing helicopters on the beach and taking a water rescue from the ocean to a sandy CPR scenario with lifeguards, to an ambulance crew, all the way to a flight crew, and have a full continuum resuscitation care for you to practice your skills and learn and develop new ways of everything that you're listening to this episode. So once again, May 6th and 7th, the Lifeguard Project's first annual Responder Roundup on the Central Coast of California. You'll see the link in the bio for the episode. Thanks for letting me interrupt. Hope you're enjoying this one.
As a lifeguard, so how long did you lifeguard before you started kind of moving on to the more professional facets like med school and all this stuff?
Yeah.
Talk to me about your lifeguard time on the beach.
Yeah, so I started out and kind of immediately went full time my first summer, and volunteered every weekend that I could, and did that all through undergrad, which I did in Florida as well. So you know that takes me up to kind of 2002. And went through undergrad with the idea of doing pre-med, did all the prerequisites and all of that. And then I just said, man, I just want to be a lifeguard forever. I don't even want to go to medical school. I just want to be a beach lifeguard forever. And, you know, I was traveling to the USLA competitions, was never in the top 10 on anything, but man, I couldn't be happier to be part of the team, carrying equipment, coming in next to last on everything, and just having a blast. But meeting those other lifeguards from around the country and around the world that were doing similar things. And especially some of the Aussies that do the endless summer, right? They come in their winter and come in guard in the Outer Banks and Southern California and those areas. And I thought, man, I want to do that. And at the time, our lifeguard agency was under Parks and Rec. And there was always that chatter, as there frequently is, that, well, one day you're going to get absorbed by the fire department. One day we'll be part of the fire department. So you should go to the fire academy, and then that way you have a leg up. And so I went to the fire academy and got my my firefighter 1 and 2 certificate. And then they said, okay, well, all the firefighters have to be EMTs. I said, okay. Went to EMT school. And then they said, well, if you're a supervisor now, so if you want to be a supervisor, then you got to go to paramedic school. No problem. Signed up for paramedic school. And then while I was in paramedic school, it was myself. By then, I had 8 or so years on the beach, and the 2 people with me had between them 30 plus years on the beach. And so when we got to the drowning portion and they said, here's the paragraph of what happens with drowning, all of us kind of raised our hand and just said, hey, just so you know, like between our 40 years of experience, like that's not what we see. That's not what our experience is. And
this was in medic school?
Yeah, in paramedic school. Yeah. And then we were told, like, well, it's what's in the textbook. It's what happens. And it was that moment that like just angry at the world, like kid wanting to fight everyone for everything and real or perceived injustices. I wanted to stand up and fight it. And I said, you know what? I'm going to go to medical school and I'm going to rewrite this textbook. And then I'm going to send them a copy of it so that they can see. And then I kind of started looking around, and there wasn't much representation in the drowning community as it translated down into that textbook, paramedic, EMT, lifeguard level.
Did you have any notable like drowning calls during the lifeguard time in your career there?
Yeah, absolutely. So I had a couple of rescues. One of my first ones, my first season, I had a junior lifeguard sitting on the tower with me it was one of our guard sisters who was a year younger than me. So it was like somebody my age on my tower on a gray overcast day like this. And there's, 2 people in my water, and one of them was a girl 8 or 9 on a boogie board. And, she's starting to drift towards the rip. And so I whistle at her and she looked up at me and then had a seizure. And so immediately I start freaking out. I throw my flag, go out and get her. And I'm a scrawny nothing kid at the time. And so I'm dragging her in. She's completely blue. She's foaming. And I've only gotten her into waist deep water by the time the truck arrives with the rest of the reinforcements to pull her out, and she's just completely blue. And we're bagging her. EMS meets us down there in the sand, and they carry her off. She had a history of seizures and just happened to have a seizure in the water that day and drowned as a result of it, but she survived, neurologically intact with no deficits. And that had a real impact on me.
Yeah. And then so medic school, you've got this spark of like, okay, this is not like how I've seen it. This is wrong. As you chase that kind of feeling of, hey, I can do this. Why did you choose to actually see that through all the way versus like stopping somewhere in the, because we're here now, right, with you as one of the leading guys with this subject matter, as an idea, but now you have some like the history to show for it. You've been doing it X amount of time. What kept that momentum for you? Because it didn't fade, right?
Yeah. So it was interesting because I had applied for the local fire department and had my interview and everything all set up that, the day before my interview was when I made that final decision to like, no, I'm not going to pursue that path. I'm burning the ships on the shore, and I have to go forward with it. And I felt like I had an advantage over some of my med school colleagues. By then I'd been out of school for 4 years. I applied all over the country. I got one offer, one interview, and that was it. And wound up at the University of South Florida on a wait list until right before school started. And by then I'd been working 4 years, some as 4 years after undergrad, and still working as a lifeguard, worked as an EMT and an ER tech at the Level 1 Trauma Center there in Jacksonville, and even was dispatching in the flight center because I didn't have a computer at home. I was like a broke lifeguard and needed a computer to be able to study. And once I got into medical school, I felt like I had that advantage because I knew what I wanted to do. I knew I wanted to do emergency medicine. I knew I wanted to focus on drowning, and I wanted to connect to that community. So to sidestep a little bit, what I really consider the modern era of our understanding of drowning really started in 2002 with Joost Beerens, who's an anesthesiologist in the Netherlands. And I'm not going to attempt the Dutch pronunciation, but it's the Society to Rescue People from Drowning, was formed in 1767, one of the first in the world, and it's still active today. And so they actually organized this conference in 2002 to try and gather some of those world experts. And the next one wasn't until 2007. So when I started medical school in 2006, day one, I was in the dean's office saying, on this date in 2007, there's a conference in Portugal. I need to arrange my schedule however it takes for me to be able to attend this conference. Whatever I miss that week, I need to be able to make up, and I will build my entire schedule around being able to attend that conference. And they were able to accommodate. And that's where I first met, just the absolute giants in the industry: Steve Bierman, Linda Kwan, Dave Spillman, Joost Beerens, who have all, been my mentors and friends now. And they were the ones that showed me, there is a path, there is a way to make a career out of it. And I, frequently joke along the way that I just saw that this niche of drowning information, of needing that drowning information translated to the lifeguard, was there. And I wanted to fill it. And there just was not a lot of other people to fight for that, because it was such this like niche side thing that had always just been copied and pasted from those previous textbooks. But being able to attend that conference as a med student in 2007 was amazing for other reasons too, that I know we'll talk about later.
Mm-hmm. And for those that aren't very familiar, as a timeline of the progress of drowning science adapting, where in the timeline was that? What was happening in the drowning world at that conference? What were like the things that were getting talked about at that 2007 point?
Yeah. So in 2002, there was really a lot of the like, what's out there, like just trying to figure who's out there and what's going on. And when I went to that conference in 2007, both myself and many others that I've spoken to since then, we kind of went with this idea of this, like, I'm this super cool beach lifeguard, right? We are the badasses of the world. We work out all day, every day. We only surf during the 1 hour when we know the tide and wind are perfect. We're not out there with the kooks the rest of the time, and just have that 10,000 hours of watching the water to be those experts. So this conference, we're going to talk about how cool we are. We're going to talk about the best equipment, the coolest jet skis, and all of that. And there was this thick, bespectacled doctor from Bangladesh who got up there and said, we did this massive survey of more than 150,000 households and went door to door and asked them, how did people in your household die? And they published the Bangladesh Health and Injury Survey and showed us that more children in Bangladesh died from drowning than infectious disease. And by the way, more than 90% of the world's drowning deaths are in low and middle income countries. And for me and many others there, that just blew our mind, right? Because yes, there's the resuscitation side of things, but also on the prevention side of things is, man, as a beach lifeguard in a high income country, in a municipality, on a tower, I only have span of control of the 100 yards on either side of me. And I'm kind of focusing on less than 1% of less than 1% of the problem. And so when they put forth innovative solutions like creating daycares, like playpens, and showed that those had a dramatic reduction in drowning, that's what really formed for me of the like, man, I need to broaden my scope. I need to look around and see more of what's out there.
Yeah, like I'm not as hot shit as I thought I was as a lifeguard, right? You're like, oh wait, there's bigger things here.
Yeah, absolutely.
You told me earlier, but just expand on what you just said about the daycare and how that pertained to this Bangladesh situation.
Yeah, showing just the absolute power of data, right? And when you have data, how can you make effective interventions? And they found that most kids drown from 9 to noon within a few meters of the home, while the primary parent, which was usually the mom in those areas, was doing the chores for the day while the dad was away working, because it's those lapses in supervision. And for those that don't know, Bangladesh the landmass is about the size of Iowa, but a third of the landmass disappears during the rainy season, and the population is about half the U.S. So imagine putting half of the U.S. into Iowa, and then a third of the landmass disappears in the rainy season.
Wow.
So water is just everywhere. Water is just absolutely everywhere, not only in overloaded boats and transports to and from work, not only in fishermen, but irrigation of fields and just drainages, and just water is everywhere around the home. And so when they created these creches, these daycares, they aggregated all of the kids into one place, and the other parents did kind of the chores for that one parent that was watching the kids at the creche. And they were able to engage in a multi-sectorial fashion, road traffic accidents, burn safety, poisoning, animal bites, right? And while the kids are in a daycare not drowning, they're also not getting hit by cars. They're also not getting burnt by the cooking stove that's built into the mud brick. And so they were able to show a dramatic reduction in drowning deaths from something as simple like that. But there's no like calendar of like, here's the sexiest lifeguard, right? Here's the sexiest prevention stuff that's going on in the
check
in the
out
world.
our data. We should make data sexy.
Right.
A sexy data calendar. Yeah. And I love that. And I jokingly, because you just did the lecture here at the conference and watching, I jokingly told Jason, I hate watching your lecture, but it's because of that, what you just described. I thought I was so cool. Hey, I work as a paramedic, as a lifeguard, as a flight medic, whatever. I'm so cool, right? No, like it's that other kind of boring, quote unquote, type stuff. Those other things where you're like, hey, have you thought about this? And each time I learn from your teaching there is I realize there's a new thing. God, that's, there's this angle, we could do this way, all this stuff. And it's not, like you said, the photo of the lifeguard, making a rescue, do all that stuff. Although it's one facet of it, but it's like, what's the broader, as you increase in those layers of your impact, where's the one that makes the most impact, right? And finding that source and what you can change, right? Well, so getting into then the drowning stuff there, walk me through what that looked like as you kind of started down this path, and how, one, like I think a big picture item was like the definition coming together. It said they maybe touch on that, those early things of the pathway that you found through med school, just like as a chronological piece. Definition is changing. Hey, we found out this. Now we can gather more data from that point on.
Yeah, absolutely. So, before 2002, there were 33 different published definitions of drowning. And the one that was probably the most confusing was near drowning. And so many of us would think drowning equals death, right? And if they didn't die, then it was a near drown. Well, if somebody has a heart attack or stroke and survives, we don't say they had a near heart attack or a near stroke, right? You had a motor vehicle collision but survived, so it was just a near motor vehicle collision, right? It just didn't make sense. And so we got to the first group that got together in 2002 said, we want to talk about drowning as a process. That process starts when there's respiratory impairment from submersion or immersion, which the big difference being if I'm in whitewater with an appropriate life jacket on, if I'm in heavy surf getting pounded and buoyant, but I can't breathe because I'm still getting hit by spray, because I'm still getting hit by water, if I'm coming down a water slide wrong and I'm having all that water forced into my airway, even though I was never completely underwater, I still drown, right? And that process starts with that respiratory impairment and then can either result in death or survival with or without some degree of brain damage. And so we've really moved away from those other terms that really don't have a clear medical definition, because even some published definitions of near drowning said death before or death after 24 hours or other arbitrary timeframes. And then from the data scientist perspective, as a beach lifeguard, I can go out and rescue somebody, bring them in, CPR in progress, send them to the hospital, and then when they're pronounced dead 3 minutes, hours, days, weeks, or months later, their cause of death is anoxic brain injury and respiratory failure, right? So they never drown. There was never a drowning at our beach, and that data might not be collected to effectively capture what happened, right? So then the city says, well, you guys don't do anything. You're not even rescuing anybody. You don't have any drownings. There's no benefit to having lifeguards here. So we can cut the funding. We can trim this here. We can pull those from there. We can reduce your service hours, drop the number of FTEs that you get per day. And it's going to be fine because nothing is happening.
And the example I use all the time is if we do our job well, nothing happens. You have nothing to show for it except for your budget went lower because you're paying lifeguards to be there. But everyone comes to the beach happy. They leave happy. There's no news story, but you worked all day, and the presence and the prevention is the actual thing why that happened. But no one sees it because they're on vacation. They look around, lifeguards here, whatever. They're just tanning and checking out chicks, right? And it seems like the drowning world is so plagued with these how would I say, contradictory things like that, right? Where you're like, okay, no one's making money off this. No one understands it as a actual definition because we don't. Now the data from the EMS call to the coroner classifying it to all this stuff, even if we wanted to look at the data, it's compartmentalized at best, right? Let alone third world countries where, there's nothing, right? The data, or what does the World Health Organization say that it's likely we have this much data, but it's likely however many times more than what we actually have to show in these other countries, right?
Yeah, absolutely. And just a lot of the data collection by the UN and World Health Organization is extrapolated and estimated. And in a lot of low and middle income countries where the drowning person may never make it to an EMS system, right? So they may be buried in the local village by local custom, especially in those countries where the local customs dictate that it be done within a certain amount of time, and those aren't necessarily captured in the data. And what can be so difficult with drowning is because all prevention, when you distill it down, comes down to one thing: changing human behavior, which is the hardest thing to do. And I'm old enough now that there used to be smoking on planes and smoking in restaurants. And if you look back on news stories from the era, restaurant owners were screaming, saying, if you don't let people smoke in restaurants, nobody's going to eat out anymore. You are going to kill the entire industry. No one's going to get on an airplane if they're not allowed to smoke. And I love the ones too with the seatbelt laws. When seatbelt laws came out and the absolute outrage of people of now the government's telling me that I have to put this thing on me while I'm driving.
I can't drink and drive.
Right. Yeah. And there's no shortage of those that you can find. And sometimes that change, and we can laugh about that now, but 25 years ago, that was a very serious discussion being had in the public halls.
Yeah.
And so how do we now change that human behavior, especially when 80% of drowning deaths are males? And so how do you take an adolescent male who's at that critical decision point of, do I do this thing that's potentially dangerous? Do I recognize the danger? Do I say yes or no, right? Do I go in and do it, or do I not? And so, I was telling you earlier, there's not a lot of nonprofit groups out there dedicated to not touching hot stoves, because you touch the hot stove, the feedback is immediate and severe, and you know what you did wrong and you know how to avoid it in the future. Unfortunately, with so much of drowning, is you can sit in the stand blindfolded some days and nothing bad ever happens. And so then that reinforces for you that sitting in the tower blindfolded is okay, and everything is okay until it's not. And going back to the best lifeguard is a dry lifeguard. And if we do our jobs properly, people don't even know that we're there.
God, I am so annoying interrupting you again. But seriously, all jokes aside, these skills are not learned by listening. They're not learned from a PowerPoint. These skills are learned by getting sandy and wet on the beach. So please, May 6th and 7th, the first annual Lifeguard Project Responder Roundup is going to bring everyone from lifeguards, EMTs, paramedics, flight crews, nurses, and hospital staff together to do drowning skills, all focusing on the most high-fidelity, hands-on experience. Links in the episode. Hope to see you there. Okay, bye.
And the more we talk about it, like the more I think about the frustration of, you going through that process to tackle that. Like you said, the immediacy of this issue is such that, like the normalization of deviance, right? I don't get the negative feedback because I was playing on the rocks and never got swept off of it by the shore break every time I was fishing. And then the other day, the wrong swell, the wrong whatever, I get swept into the ocean and I die. And boom. So you don't even get to, the family now is suffering from it and all that stuff, but it's so immediate and so confusing leading up to most your baseline knowledge, what people have about drowning or risk perception, all that stuff, especially around water, that you don't get that chance on the back end to like I said, hot stove doesn't kill you. Now you know not to do that again, though. Here and in our environment, right? Beach, lakes, all stuff. Usually people are there. Their guard is down. They're there for vacation. The last thing they want to think about is being told what to do or why this is a bad decision, right? So I just feel like every part of it is like this frustrating illusion that is like those toys that you squeeze it and it gets out of your hand. You're trying to catch it, but you just can't.
Right.
What are some more, as you kind of progress through that, what are the big things that did latch on and the big changes people should know about that now looking back that went, hey, we realized, hey, reframe this. Like one of the things that you and Schmidt both told me, right? Like drowning is a brain problem with lung complications, right? Little reframings of let's call it more the clinical side, understanding, breaking that graph of where this person's going into hypoxia and all that stuff. What are the big kind of green lit things that you said, hey, we finally got this to stick. We finally got this to stick, that someone that maybe has a basic understanding of it should be aware of?
Yeah. So just like in cardiac arrest, in drowning, there's a chain of survival as well. And it's essentially prevention, rescue, and treatment, right? Prevention being the most important. I often say that smoke alarms and fire suppression systems save far more lives every year than the coolest advancement in burn surgery, burn therapy, turnout gear, or fire apparatus. But again, it's not as impressive. And then in training, especially for professionals, we spend so much time on the rescue side of it, the technical rescue, because that's the risk to the rescuer. That's the most technically difficult, requires the fitness, the kit, and all of those other things that go with it. And then once prevention has failed, a rescue has been performed, and now we're at that last link in the chain of survival is the resuscitation and providing medical care. And so that's what really, I think, has become my niche in the industry, instead of trying to eat the whole elephant, right? Those are the bites that I can take. And what pushed me initially into this and a little bit more of the general history of just the concept of CPR and doing external chest compressions and rescue breathing of some sort didn't come about until the mid 1960s. The idea of having EMTs and paramedics in an ambulance instead of a hearse wasn't until the late 1960s, right? And then now, as we've tried to expand out to try and make CPR a public health intervention and spread it so that the soccer moms and dads, the accountants, the lawyers out there can intervene when it's their spouse, their parent, their child that needs it. We tried to take some of that ABC, airway, breathing, circulation science, and teach it to everybody, even the non-medical people out there. And what we found, especially leading up to the early 2000s, right? We'd only been doing this for 35 years by then, was that there was a lot of hesitancy to give rescue breaths. There was a lot of hesitancy to do that because it was technically difficult and it's gross, right? Now on the market, there's hundreds of different barrier mask devices and things like that fit on your keychain or whatever, but there was a real hesitancy of the public. And so we didn't see much improvement in CPR, out of hospital cardiac arrest survival rate, because there was a hesitancy to do CPR. So then we kind of shifted to this idea of compression only for people who have sudden cardiac arrest and doing public access AEDs. And, now we're up to like 2005. And that really is the focus on how can we get more people just doing something? And how do we make that something easy enough for anyone to learn quickly, retain in the most frightening moment of their life without having trained on it in the last several years, and perform? Right? How can we have our dispatchers, our emergency services 911 dispatchers, give those directions how to do it over the phone to somebody that they've never met that's having the worst day of their life when their heart rate's 180? Unfortunately, a lot of that kind of carried over into the drowning resuscitation world. And the focus inappropriately was on that compression-only CPR. And in drowning, the heart has stopped because you've run out of oxygen. And so if you're doing compression-only CPR without a focus on giving them breaths, then you're just kind of circulating blood with no oxygen. And so it was really trying to say, hey, for the professional rescuers, for the parents who are taking a CPR class because they have a pool, because they have kids, you need to take one that has breaths and compressions, so that in that critical moment, you've practiced breaths. You know what that looks like. You know what the numbers are, because the numbers are different than if you're just doing chest compressions alone by themselves with nothing else. And really, it's been a big reframing of that.
Yeah, and it got kind of, once again, another variable of it getting sidelined, because it is generally right out of hospital cardiac arrest from someone that's going to be of cardiac origin, and those compressions are what's pumping around blood that's has oxygen residually left in it, and it works. And if you put that blanket over the U.S. with more people trained, the chances are likely that it's going to be, something that's effective for that situation. But here is drowning as a down to the physiological principles of it getting sidelined based on that initiative, which is obviously a great initiative that's probably saved a bunch of lives, right?
Yeah. And even for a lifeguard, right? The reality is most lifeguards in Western countries are more likely to have somebody with a sudden cardiac arrest coming out of the locker room, coming out of the parking lot, walking down the beach. They're more likely to encounter that than they are a drowning resuscitation, just from sheer statistics.
Yeah.
And so how do we take our 16-year-old seasonal lifeguard, and I don't say that disparagingly, I say that as kind of the lowest common denominator in our industry. How do we take that 16-year-old seasonal lifeguard and teach them, when this happens, this is your focus. When this happens, this is your focus. And also, the person you're resuscitating looks like your little brother or sister, and you're terrified. And at 16, I didn't have the life experience to cope with those things, and let alone like now have to kind of be in charge and held to the same standard as the doctors and nurses and the paramedics, because I took the same CPR class they did.
Yeah. Now they're kind of veering towards the clinical part of it too. Can you walk me through some of those changes or mindset for someone who there's still, I find it all the time, training and all stuff. We have that habit ingrained in us as this compressions, ACLS, all these things are like all that cardiac focused stuff in our world. So for the professional rescuer under the drowning context, from, just graduated lifeguard academy, I've got my basic CPR, patient assessment and bleeding control skill, to let's call it like flight medic or even nurses and doctors, and getting towards that hospital part. What are the things we should be reframing for the drowning context as a clinical skill set or a mindset that you think are the most valuable to kind of share, generally speaking? Once again, not medical advice, but just like, hey, like, this is the physiology, this is what's going on. Here's how, like the thing you showed in your lecture, the opening the airway, the jaw thrust, most people don't know this is why the tongue is getting released, or little things like that you think would be the most valuable as a spectrum of increasing clinical provider knowledge.
I love that question, because I think you absolutely perfectly missed the point, which is great.
I love it.
Yeah, because to go from somebody in the water who goes under the water to the time they're dead from drowning, 10 minutes or less, right? Mm-hmm. So by the time the paramedic gets there 11 minutes later, by the time they get to the emergency department 40 to 70 minutes later, by the time they get to the ICU 3 hours later, right? What mattered most, again, once that prevention has failed, is what the lifeguard did. And I tell lifeguards all the time, what you do matters more than what we can do downstream. You as the 16-year-old seasonal in the stand, obviously on the prevention side, but even on the resuscitation and treatment side, you have more impact than the EMTs, the paramedics, the nurses, the doctors, and the intensivist along the way. And so my message then, to answer your question for everybody downstream, is really directed to the lifeguard. Everyone else can listen and it applies to them too, but it really comes down to that lifeguard, and that is their drowning process is going to continue until they get oxygen to the brain, right? Not once they get on land, not once they get on a stretcher, not once they get into a boat, not once they start getting chest compressions with deoxygenated blood. It's going to, their drowning process is going to stop, and you're going to start reversing their drowning process when you get oxygen to the brain. So for those most progressive lifeguards with that training and the skill, that might mean starting rescue breathing in the water. That might mean giving a few breaths and realizing, okay, I've got this gnarly swim in that's going to take me another 6 minutes, or there's a boat that's going to be here in 6 minutes, or there's going to be 4 more guards out here in 6 minutes. I might stay here and just do mouth to mouth with or without a barrier device in the water until there's additional resources, right? Even thinking of the pool and water park lifeguard. If I get somebody to the side, they're not dying of being on dry land. They're dying of lack of oxygen to the brain. And so instead of me struggling to pull them out of the pool, I can stay at the side and just give them rescue breaths until the extrication team and the trauma bag team and 6 other people show up in 90 seconds. We can just hang out in the water and do rescue breathing.
Versus those 90 seconds being me by myself trying to pull an unconscious person up to the side of the pool.
Yeah,
right.
Completely inefficiently, right? Because they're not dying of being on land. So now we extrapolate that out, right? You get them on land. there's getting oxygen to the brain and everything else, right? They're not dying of lack of having an IV. They're not dying of lack of having epinephrine or backboard or cervical collar. And one of the things that complicates drowning resuscitation is when we are unconscious underwater, but not quite dead yet, right? Unconscious, but not quite dead. That's you and I every night when we go to sleep. We're unconscious, but not quite dead, and we still have protective airway reflexes. And so as that drowning patient is underwater, they will, as water fills the mouth, they will reflexively swallow it down. And so they wind up with large volumes of water in the stomach and small volumes of water in the lungs, so much so that when they come out, they're going to vomit, right? Nearly 90% of drowning patients vomit, but also you get the surfactant layer of the lungs mixed with that small amount of aspirated water, and it just creates copious amounts of foam. And so many of us are so ingrained in that training of clear the airway, clear the airway, clear the airway, clear the airway. And if it's water or vomit, of course you want to clear that. But if it's just that foam, right? I used to, when I would do this presentation in person, I would take the gallon jug with this much water in the bottom of small couple mLs of water in the probably 50 mLs of water in the bottom of it, put 2 or 3 drops of dish soap and then shake it up, right? And now the entire jug is full of foam, right? Our alveoli are at the very bottom of that. So no matter how much I suction that foam from the neck of the gallon jug, it's not doing anything at the level of the alveoli. And so what I'm doing is suctioning them to death, right? And instead, you can just give rescue breaths through the foam. You can just bag them through the foam with proper airway opening, because even once they're intubated later on, right, then oftentimes, sure, we're going to do some suctioning, but we're really going to just increase the pressures, the PEEP for the medics out there, and then push that back in, push that foam back across that alveolar membrane, and it'll be absorbed. And my message often to paramedics is, that's instead of they're not dying from lack of being on land, it's they're not dying from lack of plastic in the mouth. Right? They're dying from lack of oxygen to the brain. And we've really seen that shift in resuscitation science over the last 7 or 8 years with the concept of DSI, or delayed sequence intubation, where it used to be we would just show up and RSI somebody, give them the paralytic, give them the sedative while they were hypoxic in the 70s. And now we'll put them on CPAP or BiPAP to optimize their oxygenation before we transition into endotracheal intubation. Similar on scene with that drowning patient is optimize just some bag mask ventilations with a PEEP valve or whatever you have before then jumping to that, right? Optimize the basics and then transition into the advanced, because if we do nothing now and then have a perfect intubation 6 minutes from now, we've just lost 6 minutes of brain, right? If we can start even with just bagging them on room air. Feel like I'm kind of going back and forth, but my message then for the EMTs who have gotten really good at the concept of team-focused CPR, where the first person out of the back of the bus knows I'm going to be the chest compressor. I'm going to just find the patient and start compressing. Second person in has the monitor with the defibrillator. Third person in has whatever and on for their protocol. I say, when you know you're on your way to the drowning call, right? Be the person that gets out of the back of the bus with BVM in hand and run to the backyard, right? I promise you, you will find the person that everyone's standing around yelling about, and just start bagging them. No tap and shout, no are you okay? Just start bagging them. And then I promise you, the person with the green bag, they're going to find you, right? If you had it with you and it's already hooked up and on as you're running, great. But it's better to start with room air and imperfect now and then improve, right? Because those 30, 60, 90 seconds make such a huge difference in those critical first few moments.
And there's so many, what comes to mind when I hear you talk about this is the amount of nuances from surfactant versus vomit versus fluid versus water coming up from the stomach, differentiating, deciding. How I've been opening the airway on the fidelity of mannequin or real human. Can I perform? One of my pet peeves is being able to perform a correct jaw thrust, right, to get that tongue up and off. A really good mask seal, not, squeezing the bag the right way, not too much, not too little. All of these little training frameworks, but also rethinking versions that all of the spectrum of responders need to realize. And I'm going to try to stay on track too, because I got like 10 different things I want to talk about. But one of them being the humble recognition as the brand new medic who just came out of school, like, oh, finally I get to intubate someone in the field, right? Knowing that maybe they need to yield in the moment. Let's say they're arriving at a similar time and they're at a water park with a pool lifeguard there, which we talked about in the lecture, like, hey, it's not just a pool lifeguard. This person has specifically been trained to understand that aggressive hypoxia reversal that is needed in breaking this chain or this process of drowning. Yield to them for a second, let them do their thing, especially if there's still extrication happening, especially if they understand or they've been trained appropriately. And let's meet towards that similar understanding of, okay, you're doing this part well. I don't need to come in blasting doors open and elbowing my way because I'm the highest medical on scene. If actually maybe that pool lifeguard has trained in this context slightly more than I have, right? And this is like, as you're disseminating this, you're going to have varying levels of this understanding in different departments, different agencies that have protocols or don't have protocols or approaches to this stuff. But as a baseline, what you said, like that first 10 minutes, or let's say the off-duty doctor who shows up to try to help out when there's just a couple lifeguards and they're at the water park with their family, right? Hey guys, like, we got to do all this fancy stuff. We've all seen it before on your scene. The doctor comes in. Oh, I'm going to tell you all these different things. You use an example similar that you could probably say better. But there's just so many little micro movements that we need to reframe, it seems, training with that.
Yeah, absolutely. And I think that speaks so much to the importance of cross-training and knowing your responding agencies, right? And I see so many times where the first person on scene to drowning, whether it's at a guarded or unguarded facility, is the police department, right? And oftentimes their training is tourniquets, Narcan, and an AED. And so when they see the drowning patient, they know they don't need a tourniquet, but they're giving naloxone and they're applying the AED and doing compression-only CPR. And not to disparage them, but that's what they've learned, right? That's their focus. And so if you have a police department that is progressive, that's carrying AEDs, because not all of them do, right? That shows that they're willing to interact with that portion of the community, right? They're carrying the naloxone, right? Why not have the discussion on if they're the first there for drowning? And I've just seen so many heartbreaking videos of police officers as the first on scene doing the best that they can to what they're trained to, and then there may not be a good outcome, and that imprints, right? That's heartbreaking for everyone. So whether it's a guarded or unguarded facility, it's interacting with the police, with the EMS, with the local lifeguards to say, here's what our capabilities are. Here's what we do. Here's the entrance. Here's the exit. Here's the best way in and out of that building, and doing some of that pre-planning. And then the other thing that comes to mind with it is, we saw this in emergency medicine, when supraglottic airways, whether, thank goodness we're not using combi tubes anymore, but whether it's Kings or iGels or some of those other things, I saw too many of my colleagues, when an out-of-hospital cardiac arrest comes into the emergency department, first thing they do is remove that and then go to intubate. And it's like, that thing's been working for the last 17 minutes and they've got good and title. why did we remove that device,
If it
right?
broke, don't fix it. Kind of.
Yeah, it's working. That's good enough for right now. Sure, we need to change it out in a little bit, but in these critical first few minutes, we don't just need to undo all of our progress. And like you said, you may have lifeguards that are better trained in that specific environment to operate and to do that. And they've trained on that scenario with their equipment at that facility, on that deck, on that beach, and they have something to add to it to then integrate, right? And those conversations are always better beforehand. Those face-to-face and knowing those names and knowing what the ranks are, even just looking at, the lifeguard knowing what stripes mean, to know who to point to, who to ask for something, who to communicate to, right? All of that is better when you're not in crisis.
And all of those, I think this is what people forget, because you watch it on a PowerPoint. You're the training guy. You're going, I'm the dude. I'm so cool, all this stuff. But then you forget, oh, crap, wait, I haven't opened all my intubation stuff with wet gloves before, and I just helped bring this kid out. Now my gloves are wet. The paper is harder to grip. That supraglottic airway now has taken me an extra 30 seconds to open and lube up and address, right? That's actual physiological time from reversing hypoxia based on these micro movements you're describing, which are so simple in nature and logistical, not even clinical. Right, just knowing we're going to walk through this door. We know the lifeguards have this thing here, and we're going to exit this way, and decreasing that time to the brain getting oxygen.
Yeah.
Right. I want to do just a little like lower level clinical stuff and kind of more common questions like most people have still. And I'll just kind of popcorn you, like just hit you down with all these things. Saltwater versus freshwater. And thoughts on that and what people should know.
So no difference in treatment. The treatment is exactly the same. And in the old school mentality that we need to do something different, because with salt water, the body's going to pump water into the lungs and they're going to die several days later, or with fresh water, it's going to burst all their blood cells and make them hyperkalemic, was based on dog studies done in the 60s and 70s, where they intubated dogs and just poured massive volumes of water that are more than 10 times what we see in actual human drowning, to create those abnormalities. And the final common pathway, regardless of the type of water, is lack of oxygen to the brain. And salt water, fresh water, chlorinated water does not predict mortality. Really, what does is how long was the brain without oxygen, which in drowning we measure by how long were they underwater.
What about just a quick addition to that kind of long term? Let's say they're still kind of unconscious in the hospital, and they've got it regarding like what people might be thinking about, like infections and pneumonia, all this stuff later. Have you seen differences on that, like a more long-term drowning victim and that like intubated patient that's sitting in the hospital for a little bit longer?
Yeah.
And those differences?
So that's another one of those tricky things. So the bottom line answer is empiric antibiotics are not necessary. And you have many drowning patients who have a fever from the inflammatory cascade of the event, and then they have an infiltrate on chest x-ray because they've aspirated, and that gets treated as pneumonia, which we know better with our antibiotic stewardship. And so all of the guidance really is, your sputum cultures should be your guide and not that initial fever, unless it's a known dirty body of water with known specific pathogens, whether it's bacterial or fungal. Empiric antibiotics or antifungals aren't indicated. Same with surfactant, same with steroids. We've just never really been able to find a benefit in any of those.
Mm-hmm. Cold water versus not cold water. People ask all the time, well, what if it's a cold water drowning? What should my resuscitation? Yeah. What should I change? What should I not change?
So a couple things with that is in very big picture terms, it's worse to be dying of two things at once than of one thing. So if you're dying of hypothermia while also dying of drowning, that's generally worse.
Yeah.
But we hear those rare outlier cases, right? we know that Neil Armstrong and I'm going to mess this number up, a dozen or so other people have been to the moon. That doesn't mean we're all going to make it to the moon, right? There's a handful of people that have survived prolonged submersion in cold water. But when we look at it retrospectively, those are the rare outliers. And generally, cold water has worse outcomes. As we look to the prevention side of things, in very cold water, generally agreed to be, less than 6 Celsius. But it can happen even in, sorry, I keep going back and forth between units here. That's just the way my brain thinks, right? But even in water that's 70 degrees Fahrenheit and below, you can have a cold shock response when you fall into the water. And just from the thermoreceptors on your skin being activated, they trigger hyperventilation. And that can last 1 to 3 minutes. And so if you're not wearing an appropriate flotation device or PFD or life jacket, right, when you fall into that cold water, then they often hyperventilate themselves to death. And they lose consciousness from that, or by the nature of the sea state, by the nature of their head going below water while they're reflexively hyperventilating, then they aspirate and subsequently drown. Because in the movies, we see they fall through the ice and then they've frozen to death from hypothermia in 90 seconds. But the reality is, right, even falling through the ice, if you're able to keep your airway above water, that cold shock response abates in 1 to 3 minutes. And then depending on what you're wearing, body fat composition, male body type, female body, multiple factors, right? Then you've got another 20 minutes or so of fine motor, and then another 10 or 20 minutes before you lose consciousness from the hypothermia. And so it really is that having that life jacket, having that flotation to survive that initial cold shock response.
Yeah.
So then speaking to those outliers, because I see this question most often from EMS agencies who have to make the decision, do we transition from rescue to recovery?
Yes.
And the reality is, with unlimited hope, finances, safety, daylight, we can search for everyone forever. But that's not the practical reality. So at some point, we kind of have to draw some line in the sand to say, hey, it's getting dark. Are we causing more emotional harm, let alone the physical harm of the helicopter crew, let alone the harm of the swiftwater team that's walking up and down this shore in fading light, exhausted themselves, that have been in dry suits now for 6 hours, that are sweating, that are electrolyte depleted, that are dehydrated, that they've been running on adrenaline, that they may make a mistake and become the next patient. Right? Are we
free diving, going hypoxic, aero trauma, whatever, right?
Are we causing more harm to the family with sometimes that false hope? Right? And when we I approach this from a few angles. The first is when we generally look at survival, right? Submersion time greater than 30 minutes, universally bad outcomes, right? They may survive, but be severely neurologically devastated. And it's not for me to make that judgment call to say that a family would rather have a neurologically devastated child than a dead child, right? And so 30 minutes is your most strict, but if we push that a little bit longer, maybe somebody survives, and the value system of that family is that they would rather have somebody that survives that's with severe neurologic deficits that requires 24-hour care, because that's still their child, right? And again, that's not for me to make that judgment call. And so if we're just looking at survival based on submersion time, right? 30 minutes is the most strict, 60 minutes is getting there. But then when we look at it from those outliers, right? And there was a couple of good studies that were done that said, what if we created a protocol that was able to capture every outlier? And that's what the UK Fire Rescue Services use, which is essentially to the effect of, again, to fudge the numbers a little bit, we'll start time 0 of submersion when we arrive. And then at 30 minutes, we make that dynamic risk assessment and say, is the water cold, less than 6 Celsius? Is it a small person, right? And then if no, well, then maybe we're done, right? If yes to both of those, then we check back in at 60 minutes and say, is it still safe for everybody to operate? If not, then, or sorry, if so, then, we can push it to 90 minutes, but we're not going to capture even the outliers at 90 minutes known submersion. And I know there are still organizations out there that if somebody's been underwater known for 120 minutes, they're pulling it out. They're pulling the person out and starting CPR, right? Which traumatizes the rescuers, which traumatizes the family, which I know that we'll get into a little bit later. But, these discussions have to be had ahead of time, because it's so hard to make those decisions in the moment when emotions are high, when everyone's running on adrenaline. That's the most unsafe time for the rescuers as well in that situation to potentially compound the tragedy.
Yeah. And so, once again, so many different parts of training and decision making, and the variable environments in which people operate and the resources that they have to them as well, right? All of that stuff gets brought into the conversation. Laryngospasm. People, oh, they're going to have laryngospasm. I won't be able to breathe for them initially, or, well, it lasts this long. It goes into the lungs or it goes into the stomach. Talk to me about clarifying laryngospasm and how that usually plays out.
So as you kind of said briefly in passing earlier, Dr. Schmidt, who I've known from the lifeguard days, and he and I continue to work together on many things. We've often said that drowning is a brain problem with lung complications. The problem with drowning isn't that the lungs are full of water and need to be drained by hanging them upside down or throwing them over your shoulder. It's that we need to get oxygen to the brain as quickly as possible. But for pathologists, the doctors that perform autopsies as their specialty, you can imagine for millennia, we found this dead body in the East River. Did they die by drowning after tripping and falling in? Were they killed by blunt force trauma or by strangulation and then the dead body thrown into the water? And so there's this constant search for the answer down to like microscopic or molecular level markers of things that are found in the lungs. And what really confused a lot of the understanding of drowning was there was a high number of drowning patients who were known to have died by drowning. There's no question about what happened, but at autopsy, they don't have any water in their lungs. So how did they drown? Because their lungs must have filled with water at some point. And so to try and explain that process, it was attributed to laryngospasm as, well, maybe they had a laryngospasm. But even that didn't completely make sense, because once they're completely dead and have been in there for 3 days, right, that has relaxed. Those muscles have relaxed, but there's still no water in the lungs. And the physiology is that some of that water is just reabsorbed, right? If it's small amounts, it's reabsorbed during the resuscitation process, during ventilation. Some of that gets forced back across, but even if there's no resuscitation. And the other part is, we all know, again, you've alluded to it a couple of times, how hard it is to open an airway. And the default is to have the airway not open. And so just from that physical kind of Z-track valve of the upper airway, that can prevent water from entering into the lungs. And in reality, the experience with laryngospasm in resuscitation is a very small percentage, right? Maybe 3 to 5%. And the jaw thrust, which many of the nurses that I've worked with over the years have joked that if I had an action figure, then the one move of my action figure would be a jaw thrust. And the nurses that I've worked with for many years, once they get to know me, they know that I refer to the jaw thrust as the mano de Dios, right? The hand of God. And if they have an unresponsive or unconscious patient, the first thing that they do is a jaw thrust, because that's going to open the airway. That's going to provide some painful stimulus. And that's going to kind of be the first part of the assessment as well. And anesthesiologists, who are kind of like yes, there are, and I'm going to get angry letters from anesthesiologists, but this is a little bit of the sibling rivalry with emergency medicine. But we like to joke that the final pathway on the difficult airway algorithm for anesthesiologists is cancel the case, right? That being said, obviously anesthesiologists deal with emergency and difficult airways, but as an emergency medicine physician, we like to think of that as our turf as well. But when you extubate a young, healthy person who went in for a routine procedure or surgery that was healthy when they went in and are going home healthy a couple hours later, they sometimes laryngospasm after extubation, right? Sometimes you get people that cough, that sputter, that choke, and then they'll laryngospasm. And our first line treatment is that painful jaw thrust. And doing that jaw thrust will often abate that laryngospasm. Sure, in the hospital, we've got further lines down the algorithm, but in that pre-hospital setting, if you've got a drowning patient and you're already opening the airway with that head tilt, chin lift, jaw thrust all at the same time anyways, that's going to help abate that laryngospasm. And so it's less of an issue. The bigger issue is going to be that foam. The bigger issue is going to be the vomiting. And to really put laryngospasm into context for the average person is, for the California listeners, right? We've all been at the dinner table and had some kombucha go down the wrong pipe, right? In the South, it's the sweet tea. You cough and you sputter and you gag, and that coughing, sputtering, gagging is partially laryngospasm and partially protective airway reflexes to get that water out. You take some like very panicked few deep breaths. It's a terrifying situation for a few moments, and then it abates and you go back and finish the dinner, right? And so that is kind of what that laryngospasm is it's a smart reflex. It's not a dumb reflex that just once it's triggered, it stays. Sure, that happens in a minority of airway irritation, but it's not as big of an issue in drowning as is the vomiting and the foam.
Great point. Speaking of the vomiting and the foam, you were talking about in the lecture as well, the kind of grades and survivability, and the first few boxes on there. Someone who has respiratory impairment from submersion or immersion, but they're not unconscious. They're conscious. A little bit of foam, a lot of foam coming out of the mouth, that kind of thing. Self-limiting cough. Touch on that phase and what people should understand, what traditionally would be like, oh, parking lot drowning, near drowning, all these terms that make you cringe now, right? Knowing that they're not correct. But for the rescuers to recognize, what does a lot or a little foam look like? Why should I be concerned about if this cough is not self-limiting with someone that maybe just, like you said, went down the slide wrong, they twisted and they didn't go underwater? Why did this pool lifeguard call me for this? Why did they call 911? Because this person is still kind of coughing, right? Touch on that.
Yeah. So the elevator answer, it goes back to that dinner table. And that is, if there's any respiratory symptoms beyond what you would expect at the dinner table, they need to go to the hospital for further evaluation. So for, I used to say centuries, but probably for millennia, we've known that sometimes minimally symptomatic drowning patients later die. When you think drowning equals death, then everybody that's drowned is dead, right? But drowning is a process. So you can have a heart attack or stroke like we talked about and survive. So how do we identify those early heart attack and stroke symptoms? How do we identify those early drowning symptoms while they're still conscious? And just this idea that somebody can be drowning or have drowned and be awake and conscious confuses people because of how poor the previous definitions were. And so you have, for people who have a persistent cough beyond the dinner table with some small amount of foam, right? 99.5% chance of survival. And, we call that non-fatal drowning. And the reality is non-fatal drowning, depending on the age group that you look at and the part of the world, right? There's 2 to 16 non-fatal drowning events for every fatal. So this idea of somebody's going to come out of the water and be 100% asymptomatic and then later develop symptoms just isn't supported by the medical literature. And so what happens is somebody may come out of the water and have this like persistent cough that's not right, or their mental status isn't right. I know I told the story earlier of Johnny Jackson, who was a 10-year-old, came out of the pool, wasn't acting right, and had defecated his pants, which again is not normal for a age appropriate 10-year-old, right? That's abnormal because he has some sort of hypoxic brain injury from drowning, but isn't quite unconscious yet because he still has some physiologic reserve. And then he lays down for a nap, and then mom finds him dead in his bed with foam having come out of his mouth and nose, right? So those minimal symptoms are sometimes missed, and those are the ones that can progress towards death. And so if there is that cough beyond the dinner table, any neurologic symptoms, any not acting right, and I know I gave the story as well of, I'm drawing a blank on her last name, but Lindsay, from the Mama blog, and her son Ronan, right? She said he kept having this weird cough that tensed up his whole body, and he wasn't acting right even after we were out of the pool, right? And she did the right thing by seeking additional care because he had that persistent cough. And so that's what I want to kind of teach and tell to the parents is, bring them to the emergency department. We're happy to have them. We're happy to see them, but any symptom beyond that dinner table cough, bring them in to see us. And in all of the studies, most people get better or worse in the first 2 to 3 hours. And we kind of arbitrarily expand that out to 4 to 8 hours, depending on that doctor's level of comfort. And we're doing more studies in that realm to even kind of be a little bit more aggressive with that right now.
And the message I would say to just having a lifeguard perspective, and maybe in the EMS first responder world that's showing up, listen to what your lifeguard described happened. Or as a lifeguard, if you didn't see it and mom's bringing up this kid that, hey, we were behind the tower over here and they're just kind of acting off. They were playing in the water. Those couple little nuggets of information could be enough to raise your index of suspicion to go, hold on a second here, right? And is that correctly, am I understanding that to like, hey, this isn't nothing.
Yeah.
Listen to the story, get your history better, be more of put a magnifying glass on that to get that info, even though you're looking at a kid that appears normal with maybe a little bit of a cough, right?
Yeah. And then the other side of that coin is, especially to the parents, I don't want the take-home message to be, don't worry, your kid's fine, right? If it's 3 days later, if it's 4 days later and your kid's not acting right, they've got a weird cough, they've got a fever, they've got abdominal pain, right? And it's 4 or 5 days later, take them to the doctor. But it doesn't have anything to do with them being in a swim lesson 3 days ago or 4 days ago. And I've seen cases of spontaneous collapsed lung, of infections in the gallbladder with sepsis, bowel obstructions, urinary tract infections that were all diagnosed as delayed drowning because they went swimming 5 days prior. Well, guess what? Every kid on this block was swimming 5 days ago.
Yeah.
And because they skinned their knee, they didn't skin their knee because they were swimming 5 days ago, right? It's true, and unrelated. And unfortunately, if you don't have doctors, nurse practitioners, or PAs who are up to date on that, then they can anchor on what the parent is trying to communicate, right? They don't know my language in the emergency department, right? They're remembering that one really scary story that they heard about, Francisco Delgado in Texas, who died several days after swimming in a reservoir, right? And the media picked it all up as delayed drowning, dry drowning, secondary drowning, when the reality is, he died from myocarditis, right? He had an infection in his heart, unrelated to that he was swimming, but that's what was fixated on, and unfortunately he died. And those are just educational opportunities for us and for the community.
Yeah. Okay. Supraglottic, OPA, supraglottic airway, intubation, airway tools, right? Give me the once over in a drowning context, what those represent to you, or what people should take away from those different devices and things. And
Basics. If all you have is mouth to mouth with no barrier device, start there. And I know there's people that will cringe at that, but the reality is, you shouldn't be doing mouth to mouth at work. But if you're out on the boat and it's your kid, your niece, your nephew, your partner's kid that they brought their family, then mouth to mouth is going to be better with quality chest compressions, is going to be better than chest compressions alone. And unfortunately, there are barriers to oxygen administration in a lot of jurisdictions in the U.S., even though the FDA specifically allows emergency oxygen use without a physician prescription. Oftentimes, lifeguard agencies are met with resistance from the local fire department, won't fill it for them, or the big national air gas company. I don't know if that's a brand. I'm not trying to call it any brand names here. Whatever oxygen supply company won't provide it without physician prescription. I'd love to see a world where every lifeguard has access to oxygen, but if all they have is mouth to mask, then that's the starting point. And then the next best is going to be using BVM in a mask, and then adding in oxygen. And then once you get to those, the EMT and paramedic level, again, optimizing what you have. And endotracheal intubation, especially with RSI, is fraught with its own difficulties. And so supraglottic airways and a couple specific brands have been studied in drowning with kind of mixed reviews. Some say that you can't get enough airway pressure to overcome the atelectasis. Some say, hey, it's better than nothing because we're on a moving inflatable through heavy surf, and our option is do nothing, or place this device that somebody can hold with one hand while bagging, and the other person is doing chest, plus or minus doing chest compressions. Sure, we'll do something better when we can, but right now this is what we have. And there's unfortunately just not a lot of data on it other than, handfuls of anecdotes or mannequin studies. And then obviously your gold standard is going to be endotracheal intubation, but it's a matter of, you don't necessarily need to start with that. Same with, the conversation that we had earlier about kind of the principle of DSI, even if you're not doing exactly DSI, right? You want to interrupt the drowning process with the BVM first while somebody is setting up that other advanced airway stuff.
Yeah, and stabilizing and optimizing that patient, reversing that oxygenation as much as you can with the basics to get them prepped for that RSI or DSI, right?
Yeah, and I've
without losing sight of that.
Yeah, and I've just seen heartbreaking videos where EMS arrives on scene, kind of pushes the lifeguards or the staff to the side, and, they were getting compressions and mouth to mouth, and then now they're getting 6 minutes of nothing while somebody starts an IV and then winds up doing an IO while somebody else sets up the monitor, gets that on them while somebody else is pulling the epi, while somebody else is setting up the ET tube, and then more than one attempt with the ET tube, and meanwhile, it's running. Yeah, it's now been 7 minutes since they arrived on scene of no oxygen to the brain. And then now we've got that perfect ET tube in.
Yeah. But you let them crump up until that point. Yeah. Let's say I arrive and I have, and once again, not clinical advice to anyone. And I'll put a disclaimer at the beginning of this saying, hey, we're just talking here. But let's say there isn't a supraglottic airway. I have a patient that I know it's not a difficult airway based on the parameters, whatever. Obviously securing the trachea with a cuff, right, for an adult there would be more beneficial than a supraglottic, pending your environment or what's best if you're in a rescue phase, whatever it is. But let's say you're in a perfect scenario. You're there, you're early on, you've had optimization. All they have is a supraglottic. You're going to get that tube in 20 seconds. Everything's prepped. Is that still then the better option, obviously, if that's the case? To have it secured, or is it like, hey, if it's not broke, don't fix it, leave the SGA in, or leave the...
Yeah, I would look at, what's their end tidal? Do they have a good waveform? Do they have, got a good peripheral pulse ox or central pulse ox if you have it, and they've got a good CO2 waveform? Leave it alone. Yeah, leave it alone.
Now, what about similar circumstance, but I have someone where I feel more airway resistance. I have poorer compliance with the BVM. We did suction with some benefit, right, where you're getting something there under that context.
Yeah,
then want to, airway pressures being the main question.
Absolutely. Yeah, then you would move to endotracheal intubation, and then to add on to that scenario as well. There's so much difficult context. Having worked emergency medicine and EMS in rural, bordering on frontier areas, where now I have a flight crew that's going to come in and has a 90-minute flight, right, in an EC-135 with an air conditioner that's taking up half of the space over here, and there's no visualization, there's no manipulating the patient, there's no sound, there's no communication, right? We need to switch this over to an ET tube before we load them into the aircraft for that, right? I'm sending somebody with a ground transport crew that has a 45-minute ground transport through the mountains, through the hills, on winding curves, right, with just the medic in the back because the EMT is driving and he or she is by themselves, right? Like, those are the ones where you're past that initial resuscitation phase, and now you're in the thinking of the logistics and safety of transport phase, and switching over to something more secure, right? The failure of that scenario is, compression only CPR, advanced team shows up, continues the compression only CPR with no mask ventilations at all, to then proceed to RSI or even just, resuscitative intubation.
Yeah. And then for those flight crews, or maybe respiratory therapists or hospital stuff, ventilators, PEEP pressures, these kinds of things, anything in that subject matter that's worth catching on regarding a drowning victim that does have some fluid, right? Not a crazy amount, but your increased compliance person, you're trying to battle some higher pressures. What are ones we would see maybe for your average, let's say, pediatric or adult patient? Is that something to look out for?
Yeah. So the good news is that the ventilation strategy for a drowning patient and oxygenation, but that ventilation strategy is the same as ARDSNet. So do like you would normally do with that lung protective, lower volumes, and then titrate your PEEP if the issue is oxygenation, and then your tidal volumes and your rate to maintain the ventilation component of it. But you're doing the same thing that you would for somebody with sepsis. You're doing the same thing that you would for somebody with flash pulmonary edema, or that's intubated for any other reason. Obviously, if you get into the COPD and the asthmatics, there's ventilation stuff you're going to do with them. But for the most part, it's the same as the ARDSNet.
cool. And I think that's something that people, I've heard questions of too. It's like, oh, should I be expecting some massive high PEEP pressures with these people or whatever? Or maybe you've seen, and once again, I don't want it to be like maybe an anecdotal story, but like, is that something, or is, like you said, just, hey, no, it's the same. Do with the ventilator what you will, as you would with any other case, how you would troubleshoot and all this stuff.
Yeah, focus on the basics, especially in that early resuscitative phase.
We could talk about the clinical stuff forever to a nerd out, but just more bigger picture stuff. So protocols, changing these systems, getting counties to change. So, which, by the way, thank you for your help in getting San Luis Obispo County to have a drowning protocol, which went into effect this year. Huge win, having someone who's supportive to make these changes. And like you said, go with what the science is and go with implementing something. So now the medics have something to look at and touch on. Those kind of systemic changes. What could people learn from to start being up to date and making the change needed on the drowning protocol side and kind of policy side?
Yeah, I would just, it's difficult. And, Schmidt and I have joked about this before, where we really haven't invented anything new. We really haven't, developed that life-saving clot retrieval, magical implantable defibrillator, St. Jude level device. It's really been that, how do we distill this down to the basics in an educational way that crews can train the way they fight and have that recall in that critical moment, because we've gotten really good at that with out of hospital cardiac arrest of cardiac origin and doing the team focused CPR and getting that Epstein survival there. Crews will call the patient on scene because there's no benefit to bringing them to the hospital, and they're good with that. But now it's a kid. Now it's a 20-year-old surfer, right? They want to scoop and run and make them my problem as quickly as possible without doing those necessary interventions. Again, I say that not disparagingly, but just kind of as that's what can happen. And in adults, paramedic dosing is easy. They get 1 amp of something. You don't even have to know the numbers on it. It comes in the size tube that they need, right? It's firefighter proof, right? But in kids, right, we don't make errors where we accidentally give 3 instead of 1. We make errors where we give 1,000 instead of 10, right? We make these exponential errors. And so that stress of math in the moment is difficult. The stress of remembering the calculations for RSI, for our epi, for our whatever that we're doing, right? That puts that cognitive load and that stress that then takes away from, I just need to do the fundamentals. I just need to do the basics. I'm trying to remember the calculation that I learned for what size ET tube, for what size blade to use, for what size IV, for all of those things, instead of focusing on the basics. And so really, that to your question of what can crews do to make sure that their drowning protocol is up to date, one, see if you even have one. Right? Because too often I see jurisdictions where drowning is treated exactly the same as any other out-of-hospital cardiac arrest. First in starts chest compression. Second in hooks up the monitor and does a rhythm check. Third in does the BVM. Fourth in starts the IO. Fifth in stands at the feet and turns on the metronome. Whatever it is, and it just falls into that same defibrillation compression only algorithm, instead of just reframing the focus a little bit. I am personally a huge fan of just starting with 5 rescue breaths. And there are theoretical models that say 5 is the best number, but we don't know. Maybe it's 4, maybe it's 6, maybe it's 7. But we think that 5 is probably better than 2. And for me personally, more than anything, it kind of shakes us awake a little bit in that moment of, I'm at this terrifying scene with this tragedy, and I'm the one that they called. I'm the one that had to walk up here. My heart rate is 180. What can I focus on? And that 10 seconds of myself taking 5 deep breaths while giving them 5 deep breaths gets them some oxygen, gives me some time for that mental clarity to then say, okay, now you start quality chest compressions. I'm going to continue doing this. Okay, now next person does this. Next person does this. And then to have that separate team-focused approach to respiratory emergencies, to drowning, right? Instead of the 65-year-old adult that, the cardiac risk factors who has sudden cardiac arrest, VFib, VTAC, sudden collapse, right? Like that is a different treatment priority, right? 8 minutes in, they both look the same, right? You're doing compressions, you're doing ventilations, you've got them on the monitor, you've got an AccuCheck, you're running down your checklist and your secondary survey, but it's those critical first few minutes of how do I focus my priorities. And so the training algorithm isn't any magical drug, isn't any magical anything. It's how do we remind our crews, right? Nobody rises to the occasion. Everybody falls back to their level of training. So how do we train this? And is our protocol set in such a way that we can train it? And it's so difficult because it's easy to measure things like how long did it take you to put the defibrillator on? It's easy to measure things like how fast or how slow are you doing the chest compressions and some of those things. And so those are great test scenarios when you're checking out crews. And it's so much harder to kind of say, to shift that focus to, hey, how many times are you going to try to get those 5 breaths in right now because it's a disaster and you can't do it with one hand and you need the first 2 arriving people to have one person holding a mask seal and one person squeezing the bag because we're not touching the bag 5 times to check the box that it was completed, right? Our tactical objective is 5 breaths to overcome the foam, overcome the atelectasis, get some oxygen to the brain, get some oxygen in the bloodstream to start circulating with our compressions. And maybe that means the first person in is just holding the mask and doing mouth to mask because that's how they're getting a seal. And then the second person can bring in the BVM or whatever that looks like for that specific agency instead of, oh, thank God those breaths are over. Let's go to these compressions that we practice so much more frequently.
Yeah. Reframe, simplify, and then execute it well, not by way of just going through the motions, but by actually executing it. Yeah. And I love what I'm going to start telling people. Hey, those 5 breaths, they're for you and them. That's what I'm going to say. Take those 5, set yourself up. Hey, I'm in drowning protocol now. This is my focus. It's like a quick 5 for you and them.
I'll tell a very, very quick story, but I had a friend who was a highway patrolman, and he said, I can't tell you the number of times that I show up to a collision or a scene and I have no idea what I'm doing. And so what do? I pull out my clipboard and I stand there and I stare at my clipboard. Right. And that's my reminder to like, okay, start at the beginning, start at the top. And so he had gotten into this routine of if his peers saw him with his clipboard, they knew like, okay, let's talk. Let's see what are our priorities. What do we need? What do we need to do? Because that was that sign of like, I need to reframe and refocus me because I'm still taking in all of everything that's going on. And I need those moments as an ER doctor during a resuscitation, right?
Absolutely.
I have my routines that I do. And, I hear that call of what's coming in and I talk to the staff. I have my process that I go through to get into that mindset. And, your seasoned medics, EMTs and lifeguards have that as well.
Yeah. No. And I love, I hope people listening to this will see it. We're not, like you said, we didn't make some crazy fix all, whatever, but all this time you've put in is basically just verified what you thought people said you were crazy for in the beginning. Go, no, here now I have the data to show I've been doing it long enough. And by the way, it's simple.
Yeah.
And if you train it effectively, they're nothing. And this is what I was telling people when we were talking about the drowning protocol back at home. Nothing on that protocol is anything that you haven't already done. It's BLS skills mostly done really well.
Yeah.
And with reframed in an aggressive interruption in hypoxia to the brain, right? And if you can do that and execute that through training and through muscle memory, now you're, whatever percentage closer to effecting a positive outcome, right? So, yeah, no, I mean, kudos to you for fighting that fight because you're working night shift, you're doing 10 million other things. People have been telling you that you're crazy, that this isn't going to work and this is whatever for so long, and then persevering through that to now come on the other side of having something that's tangible and effective and in the end simple to just be like, hey, here it is.
And then the other thing that I'll add to that's really for whether it's the Swiftwater, the Marine Rescue, the boat, men and women, or the lifeguards, is when I first started as a medical director in this industry in 2011, everybody was using CPR masks that had paper filters that just got destroyed by the humidity. And I looked at that and I said, why on earth are y'all using those? And there are masks out there that have been around since the 40s that just went off patent, is it's what anesthesiologists used to use, that are round and have a mechanical filter that self-purges. So even on the lifeguards that I supervise, that CPR mask is on their tube. It's in their hip pack on their person, so that when they go in the water and they get to that person to the side, or they get to them beyond the surf line, they have that mask on them. Because I had other rescues as a guard where, I run 400 yards down the beach, swim 400 yards out, bring them in. By the time the current takes us another 200 yards down the beach, it's a busy day and the truck's not there yet. And my equipment is 600 yards that way. And so I'm just going to start chest compressions, or I'm going to just tap and shout and hope that somebody shows up with a CPR mask soon, because I don't have the tools that I need to intervene.
And that's physiologically not reversing hypoxia. And based on a logistical, simple issue.
Yeah.
They have it clipped onto your tube, or like you said, on your person. And so, cool. Well, I'm foreseeing a part 2 episode because I have 10 million other questions and things. But there's just so much here. I hope this is a good step for people to be able to just clarify some of these basics and hear it from you as well. And then have something like this where they can go to a source, listen to a podcast, refresh that. Or if they're worried about, hey, the protocol, hey, we have these questions, whatever, it's easy to do. And it's,
Yeah, and I will link it. Obviously, you'll link it in the show notes. But I have my full 90-minute drowning resuscitation presentation that, in the vein of foam or the free open access medical education, will be available. Share that within your networks, wherever you are. But also in 2024, through about 10 years of behind the scenes work, the American Heart Association and American Academy of Pediatrics put forward specific drowning recommendation updates to supplement the general guidelines as well, which include really pushing for that oxygen. So my hope is that agencies will use that to kind of push them towards having oxygen if they are not already using it.
Yeah, and I'll put all those links, whatever we need is going to be in there 100%. So thanks for taking the time. Super great conversation. We'll definitely find a part 2.
Yeah,
to do it.
Yeah,
there's so much to discuss on this. So thanks for everything.
All right. Thank you so much.